Good evening, everyone, and welcome to the SAB's April educational webinar event, Leveraging Media to Ensure Progress in Advanced Bronchoscopy with Dr. Pepper. Before we begin, just a few reminders to our audience and anyone that may be new to SAB webinars. You all are in a muted mode, and if you have questions, please ask them throughout the presentation by submitting them with your control panel. There is a question feature located there. We'll address all the questions after Dr. Pepper's lecture. At this time, I'm going to hand it over to Dr. Boadam. He will be this evening's moderator. Dr. Boadam does sit on the SAB's Education and Program Committee. At this time, Dr. Boadam, take it away.
Hi, good evening, everyone. It's an honor. Welcome to the SAB webinar for April. It's an honor to introduce a very close friend, dear colleague, Dominic Pepper. Dominic completed his bachelor's and doctorate in medicine from University of Cape Town, South Africa in 2010. He then went on to complete his master's in health sciences from NIH and Duke University in 2018, followed by a year of internal medicine residency from University of Mississippi Medical Center, followed by pulmonary critical care fellowship from University of Maryland School of Medicine, Baltimore, Maryland. He then did a research year in addition to that from NIH Bethesda, Maryland. Besides being an excellent clinician, researcher, educator, what impresses me most about Dominic is his love, flair, and passion for the world of media. Dominic is the chair of the website and social media committee of the Society of Advanced Bronchoscopy, the ATS Breathe Easy Critical Perspective podcast editor, and the Chest podcast editor, having hosted over 165 in-depth personal interviews. I think he uses media to the best advantage possible to showcase and further our field of bronchoscopy and leveraging the bronchoscopists, that us, and the work we do to the world. Without much ado, I would like to welcome Dominic. Welcome, Dominic.
Dr. Boadam, thank you so much. An absolute pleasure to be on the webinar with all of you. Today we'll be discussing how to leverage media and ensure progress in advanced bronchoscopy. And a lot of us got into this space because of lung cancer. And here's a typical scenario that we've all encountered over the last few years. We find a patient who's got a 9mm spiculated lung nodule. If we diagnose it and treat it, we could offer them 92% survival in 5 years. But what has tended to occur over the last several decades is that these lung nodules continue to enlarge without biopsies. And here's a patient who 4 months later, the nodule had increased to 34mm. If they had had resection at this time or treatment, the survival would have been 50%. But in actual fact, the patient only had a biopsy when it had spread to stage 4 with survival of less than 10%. What's even more devastating about this case is that if you look back in time, a year prior to time 0, that patient had a 7mm lung nodule. And then you can even go back further, a year prior to that, when it was 5mm. And this scenario is happening every single day. 250,000 people are diagnosed with lung cancer every year, 50% of them with late-stage disease. And clearly, we need to do a lot better in the terms of detecting lung nodules, biopsying them and getting an early diagnosis and treating them. And I think that's why a lot of us have entered this space. And we're rather privileged in that we're at the cutting edge of what I think is one of the most exciting times in bronchoscopy, where we finally may be able to reverse the trend and actually increase early stage lung cancer. For the talk today, it's basically going to include 3 components. The first part is looking at what our vision is as the SAB website and social media committee. I'm going to talk you through my journey getting here, and with the hope of that you can reflect back on what you've experienced in your life and what's got you to where you are now. And then finally looking at our toolbox, what's in our toolbox to assist us with social media enterprises. So in terms of the vision for the SAB website and social media committee, we definitely want to provide engaging content that you come back and say, you know, I really enjoy that. I want to go back and see what else is there. Our goal is to make sure that we educate, that we enlighten, and that we inspire you to be much better bronchoscopists and to improve the care of the patients that we're serving. I think one of the key components that really will ensure that our field advances is to use a scientific method, not to use social media just for the sake of using it, but combining it with evidence that shows that we're actually doing the right thing for our patients. As mentioned already, we want to advance the field and actually challenge dogma. And it seems as though in every discipline that we encounter, there seems to be a component of dogma. And here in the bronchoscopy field, I'll just run you through a few things which over the last 5 or 10 years kind of was, this is how it should be and you better do it this way. Whereas things have changed a lot over the last decade. We now do, before it was said we had to do EBIS before peripheral bronchoscopic biopsy. It was recommended no peripheral biopsies if the PEEP was more than 10. It was previously said, don't do any cryobiopsy, high risk for bleeding, high risk for pneumothorax. We now do these routinely, the 1.1 millimeter cryo probe. Previously, we didn't do breath holds, we didn't do apneic oxygenations. We've had some folks putting patients on apneic oxygenation for over 20 minutes to get a better diagnostic yield. We previously were told that transthoracic needle aspirates by interventional radiology was superior to bronchoscopy by pulmonology. And the truth is, we can access lung nodules in any part of the lung, subpleural, pleural, any location with the current technology that we have. We've also been told that there's been no progress with navigational bronchoscopy in 30 years, which is not right, not true. And I'll add a bit of controversy to this slide and give another dogma that's come up, and hopefully it will change. Bronchoscopic ablation is never coming. So moving on to the journey, and one of the things that's always impressed me about medicine is how it's both a science and an art. And Heinrich von Schlegel said, every art should become a science and every science should become an art. And I think those words hold very true for what we are embarking here, trying to advance the field of bronchoscopy. When you talk about journeys, I want you to reflect on not only the journey, but the navigation tools that we use on our different journeys. When we go to a new city and come out to our hotel and decide to go to a hotel, we basically get our app out, plug the locations in, and it shows us, where we're starting, where we're ending, and we basically navigate along that path. And there we already have the map laid out for us. The same is true for the technology that we use with our robotic bronchoscopies. We have to, register our catheter, make sure it's at the right place at the beginning, and then we start along the path to whichever nodule we're going to, and then we eventually get there. And that's very different from our so-called career path that we embark on. A lot of us like to think, we started at point A and then got to point B, but the truth is, it's a meandering path, and the reason is because there is no map out there beforehand. And in many ways, it's the analogy of, are we using maps or compasses? When we have uncharted territory, we need to map it out and we need to use a compass. And the question that we have to ask ourselves is, what compass are we using to ensure we're getting the best care for our patients? What moral compass, what scientific compass? So I want to walk you through, as an example, the career path that I took to get where I am. And the reason I'm asking you to do that with me is to reflect, for you to reflect on how you got to where you are. I'm going to walk you through my path as an early undergrad to where I am now. And I want you to reflect back on, which people inspired you, which people are you inspiring, and what opportunities have you missed, or what opportunities did you take hold of? On this slide, you'll see on the top is research academics, mainly, left side of the brain, and then the media more right-sided. So as Dr. Bardam mentioned at the beginning, I'm originally from Cape Town, South Africa. We have a 6-year program. I did my undergrad at the University of Cape Town. And as you can see over here, it's a beautiful city, Table Mountain in the foreground, the 12 Apostles in the background, lovely beaches. At the back of the mountain is the University of Cape Town. And I was fortunate to be able to go there for my undergrad years. And it was during that, I think it was my 4th year of med school, where we were allowed to do a public health project. And we said, these patients aren't very compliant with their asthma medications, their control isn't good. Why don't you design a public health project to improve it and investigate what's happening? And we decided to take the slightly different tact and go evaluate, how our physicians are doing in demonstrating inhaler technique. And the results weren't good. We took in a video camera. They agreed to allow themselves to be video recorded. And out of the 7 steps that you would have in assessing asthma inhaler technique, only one physician knew how to instruct their patients how to do it. And of the remaining 6, they only knew 1 or 2 steps, which for us as fourth-year medical students was mind-blowing to think that physicians didn't know how to do that. But it definitely put that thought in my head. We need to always make sure that our physicians are educated and knowledgeable about what they're trying to do. So that definitely stuck in my mind. I then went on to do my internship and got involved in the ICU, and I was very fortunate to have Vanessa Birch, one of our instructors, who said, why don't you just go ahead and do a mini research project? And I was like, I have no idea how to do that. She says, well, just go collect some data on hypoglycemic emergencies, find out what's happening, and figure out a topic or a research question that interests you. And it ended up being about hypoglycemic emergencies to a community hospital, the financial burden that entailed, and what are the reasons for it. And in hindsight, she definitely spurred me to do a lot more during my intern year than I would have done otherwise. And as a result of that opportunity, I was recognized and invited to work for an HIV clinic that was being sponsored by PEPFAR. For those of you unfamiliar, PEPFAR is the President's Emergency Plan for AIDS Relief. HIV is still pretty rife in South Africa, and George Bush at that time sent a lot of funds to Africa's way, and I was able to get a scholarship and be employed by them. And during that process, that learning opportunity, they allowed me to do my own little research projects, so little mini papers, and ended up getting MD, which in the United States would be the equivalent of a PhD. As part of that training, I was able to go to Johns Hopkins, and I remember getting the award and them saying, "Oh, we'll pay for your courses," and very exciting stuff, principles of epidemiology and design and conduct of clinical trials. But the funding came to $6,500 at the time, and that was basically my whole salary for the year, including the transportation back and forth from America. So I was amazed at what was possible in the United States, and then actually going to Hopkins and getting that instruction was incredible. I got so enamored by the United States that I eventually got a visa and came to do my internship again in Jackson, Mississippi. I will tell you, the second time round for internship and residency is a lot easier. But there again, very fortunate to encounter people who mentored and promoted research as well as media work. Calvin Thigpen, he was one of the residency assistant program directors, and he wanted to develop the abstract program. We had a research abstract day every year, and the first year that I was there, we only had 6 abstracts submitted, and baffled all of us because there were at least 20 in each class, plus fellows, plus medical students. We could easily get 50 to 100, and we decided to work on that. So we created an abstract research day. We labeled it the ACP, or American College of Physicians Abstract Research Day, and we just got residents to write up cases that they had done, or interesting cases that they had seen in either the clinic or in the hospital. And I ended up doing one on Lemire syndrome, and eventually I ended up educating when I was a chief resident, fellow residents, and that definitely grew. The subsequent year, we ended up having 50 abstracts submitted. The year after that, it ended up being 100, and this program is still very strong. I get yearly updates. And they usually submit about 50 to 100 every year, and a lot of these abstracts end up going to the national meetings. As part of that, I eventually was fortunate to become a chief resident, and I remember going home one year back to South Africa, and my sister was in high school at the time, and she said, "Yeah, they're teaching us how to design apps on our phone." And I was like, "What?" And she says, "Yeah, it's pretty easy. You just plug this in here, you plug that in there." And next thing I knew, I came back to Mississippi, and I was responsible for designing the intern survival guide. and was able to map out an app on the iPhone. It didn't translate that well onto the Samsung equivalent, but it allowed us to have our interns be updated on the survival guide, and then each morning report get an update on what they had learned that day. Because of that app that we're able to design and use, when it came to our recruitment or to retain the next year's new interns, someone mentioned, we should have a recruitment video. And I was like, why not? So we actually ended up designing a recruitment video. It ended up being 6 minutes long, and we sent it out to all our prospective interns, and a lot of them ended up coming to our program. The platform that we used for that recruitment video was VideoPad, and $200 a year subscription, but it's actually still the same one that I'm using to create the videos that you may see on LinkedIn for the SAV. Very simple to use. You just pull in media, either photographs or video or audio, mix and match it, and the results can be pretty exciting. After I finished my chief resident year, I ended up going to the University of Maryland, as well as the National Institutes of Health. I was fortunate to meet both Ash and Ed, who are my IP attendings. I was a pulmonary fellow, and that definitely was a driving force when eventually I was able to start doing a lot more bronchoscopy where I am now. Was a driving force for me to get back involved in the bronchoscopy field. What struck me during my fellowship was the the attendings at the National Institutes of Health and their attention to detail and their concern with sepsis at the time. And there's been a lot of uproar on the different definitions that were used for sepsis. In 1991, they had one definition. In 2001, it got updated to another, and then eventually the final definition came out in 2015. And it was intriguing to me that it took the field of critical care 25 years to figure out what the definition of sepsis is, even though the definition that we have now was already proposed around the time that the first one came out in 1991. But the big obstacle to it was a lot of evidence-based medicine and folks believing that they knew it all and that they didn't want to get consensus. And that definitely rings true for the current environment that we're in now, where as a bronchoscopy community, interventional pulmonology, there still is no good consensus or agreement on what the definition is of diagnostic yield. And I think we need to get that figured out. And we definitely will be using the media platform to make sure that we are able to have consensus and agreement so that we can advance the field and move forward. So during that time, if you've commuted between Baltimore and Bethesda, you'll know it's a 2-hour drive each way, sometimes with the bad traffic. And as a fellow, we had to do critical care stuff in Washington, D.C., our pulmonology stuff up in Baltimore. So a lot of commuting, a lot of listening to podcasts. And during that time, I spent a lot of time listening to Scott Weingart give his MCRIT podcast. Each day, I'll listen to it, get into the hospital, read up more on what he had to say. But it was really great to, having listened to probably, 50, 60, 70 podcasts during that time, understanding what makes a good podcast, what interested me, what got me excited about it, which podcasts I found like off-putting and being like, nope, that wasn't interesting, let's not listen to that. Subsequent to that, I ended up getting my master's in health science at the NIH because they offered it and it was available. And at that time, our program director for our fellowship, Nitin Seem, he approached our fellows and said, we're doing a bunch of podcasts for the American Thoracic Society. They wanted to recruit some young folk, some fellows that do some sort of fellow podcast. Would you be interested? And there were a group of us that started, and I'll say this is probably the catalyst that got me involved. When he first asked, I was like, I have no idea how to interview anyone, ask people questions, what the format is, what the rationale is, and my big concern was whether people would actually even say yes. What I found, and very gracious ATS presidents responded to my request, and every single time I've asked, I've most people have said yes. And it's been encouraging to realize that a lot of people, in the top echelons of, academic medicine are willing to share their insights with fellows and junior practitioners. And as a result, I got 9 podcasts under my belt, and was able to move from that to eventually do the critical care podcast. At that time, I realized that there wasn't much scope of practice for academic medicine or research for what I wanted to do. So I realized that I needed to get a haircut and go into private practice. And that's why I eventually relocated to Pacific Northwest at Providence in Olympia. And during that time, again, I was fortunate to have another instructor, Dr. Burton Lee, and he had taught us how to, work ventilators. He had created this module where he would teach you how to ask questions, work through it, master the craft. And he, out of his own spare time, decided to instruct myself and one of my co-fellows who had already finished our fellowship on how to critically appraise literature. So he went through how to read a systematic review, how to do an RCT, how to do a meta-analysis, and that definitely stood me in good stead because subsequent to that, I ended up helping out with the chest podcast and was able to get a couple more podcasts under my belt. At this time, as most of you know, COVID happened, and it was an incredibly weird time. And most of you will remember that it seemed as though evidence-based practice was thrown out the window. For some reason, we weren't allowed to do bronchoscopies and save patients from lung cancer because we were concerned about COVID infection, even though there was data showing that we could, wear N95 masks and diagnose these patients. And during this time, I was fortunate to work with the ATS on the Critical Perspective podcast, and that was really instructive in making sure that I brought experts in the field who were sticking to the guidelines, who were sticking to ARDS practices, and promoting that sort of evidence to the communities rather than the vitamin C or the ivermectin. Subsequent to that, having done the chest podcast, one of the articles that I reviewed and I actually interviewed was the shape sensing robotic bronchoscopy at MSK, and Dr. Block came on board, and that really got me interested in robotic bronchoscopy. And as a result, I did a whole lot of reading, and one of the websites I came across was the Society of Advanced Bronchoscopy, and I was like, what, a $50 membership? I definitely got to sign up for this, and was able to access their materials. And eventually, when they sent out a request to join the social media website, I was like, sure, I'm happy to be a member. And they were like, congratulations, you're now the chairman. So that was pretty funny. So moving along, and then getting involved in the robotic bronchoscopy field is, I think a lot of you realize that we need to build a lung nodule program, build a bronchoscopy program. One of the challenges that we often encounter is speaking to senior management, the executive suite, about getting the funding that you need. And as I've seen in a lot of my fellow advanced bronchoscopists and interventional pulmonologists, we end up doing an MBA to help us with our arguments and be able to speak to leadership. And as you look at this timeline, I think you'll notice one thing, the number of people that I was fortunate to have that, threw something at me or offered me something that they didn't have to. And you may have experienced the same. The second is a lot of the social media stuff here on the bottom part. Most of it was just happenstance. I just happened to be speaking to someone who suggested an idea, and I was like, oh, that's interesting, let's go check it out. And it eventually grew and became something a whole lot more. So I'd definitely encourage you to look at prior experiences that you've had and ask yourself, what have I left on the wayside that I could bring to bronchoscopy or the field that I'm in. So that brings us to what's in your toolbox. And I think it's really incredible that you speak to so many physicians and pulmonologists and you ask them, what did you do during your college years or post that? And there's a lot of hidden talents, a lot of forgotten passions or abilities that we just haven't tapped into, a lot of right brain stuff that would definitely animate and bring a lot more to the bronchoscopy field. There's also a lot of pain points that we have. For me, it's been the issue of definitions and, why can't society or why can't our field get around a decent definition for diagnostic yield? Or why do we abandon good clinical practice? Why do we follow dogma and working against that? The importance of recognizing our blind spots and then making sure that at all times that we're creating something of value for our patients in all that we do. One of the Japanese sayings that I found really useful is, ikigai, making sure that at all times that you're doing what you love, what you're good at, what you can be paid for, because the bills still have to be paid, and what the world needs. And if you do all of that, you'll definitely advance your field. I'm fortunate to be working with an incredible team. I've got Banu, who straddles Portland and Vancouver, Washington. Issam, who's based in Willowbrook, Illinois. Julieta, who's Grand Rapids, Michigan, and she's actually finishing her fellowship shortly and will be coming in and attending pretty soon. And then Azim, who's based out in North Carolina. And basically, what we're going to be looking to do is to use social media to attract a whole lot more folks into the Society of Advanced Bronchoscopy to advance the field. And there's been a really interesting model that I encountered over the last month or so as part of my MBA training called the AIDA model. And basically, it's what our industry colleagues use every single day to get us to buy that robot or invest in that AI technology or get advanced imaging. Basically, they want us to have attention or find, oh, there's a robot. And then to develop interest in that, and then the desire after you see how someone is able to get lung nodules that you wouldn't have dreamt of before, and then action, put your money where your mouth is and buy that product so that it advances the field. And we'll definitely be using that in some of our media practices. Thus far, I know Banu has already started using a video pad and creating some really great videos that he shared on LinkedIn. And we'll be using the whole gambit, Instagram, WhatsApp, X, and Facebook, and each person on the team will be developing their own niche so that they can master it. And then obviously we'll be continuing our usual content with This Is the Way podcast. To come back to that original slide that we had, a year or two ago, I would have said, these lung nodules over here are just outside of our range. And it's become increasingly apparent that with the technology that we have today, you combine advanced imaging, cone beam CT, with robotic bronchoscopy, with particular tools, for example, cryobiopsy, you can sample anything in any portion of the lung and get an answer if you're willing to work hard enough to get there. So with that, I'll stop the webinar and just remind you, our goal, we have a vision, we're on this journey, and we need to look into our toolboxes really deeply to make sure that we bring benefit to our patients. So thank you to the SAB for the opportunity to share this with you.
Thank you, Dr. Pepper. I'll bring back in Dr. Wadham, and if anybody has any questions, just a reminder to please feel free to use your question feature, or you can raise your hand, and I can also submit a request for you to come off mute.
Of course, thank you, Emily, and thank you, Dominic. A stellar CV and a stellar journey, and an amazing end to how we benefit at the SAB with your expertise. I'll be honest with you, I'm sure there are many out here on the attendee list who would agree with me that not many of us have the tools, not many of us have the know-how, not many of us have the skills here to make it for people to know what we do daily in our bronchoscopy work. And those are the tools that you and your team bring to us leveraging media. So thank you, Dominic. I want to say thank you and look forward to many more interactions with you on both the speaking forum as well as the SAB platform.
Perfect.
And I would like to bring in Emily back. I think we have an interesting webinar coming up next,
Yeah.
focusing on the pediatric world.
Yep, there is one question here that I'm seeing. The questions are coming in. So, Dr. Pepper, what cautions do you have for folks using social media?
What cautions we have? I would say the most important thing is, and that's why at right at the beginning I said, make sure your posts are grounded in science. My concern, and I think we saw this a lot during COVID, social media is an incredible tool. It's a very powerful weapon, and it can be used to create a lot of division and a lot of animosity. And we definitely saw that in COVID, where folks were peddling, ivermectin and vitamin C with no proof. And I think we've also seen it on some of the social media posts. I think we need to realize that as physicians and as clinicians, our first goal is towards our patients and making sure that they get the best. I think we need to be very cautious of creating animosity amongst ourselves as clinicians. We aren't here to sell products for industry and to the detriment of our patients. So I'll say that's where I'd be very cautious about social media. I think also deriding either colleagues or saying things. We're allowed to have differences. I think social media is not the best place to share those divisions that we have, and have a chat in person. Go have a beer or have a drink and chat about your differences. I think we stand to gain a lot more if we work together than fight about which technology is better versus not. I think each of us have our own personal abilities, our own personal preferences, and I think we need to be careful that personal preference should not sway what benefits our patients.
I think that was well said. And again, you're right, because a lot of us, industry as well as individuals, use social media, Dominic, now to kind of not just to showcase your cases, but also to promote education and awareness of the different procedures and the different techniques that we have out there and can bring to our patients. So I think it's a very fine line between kind of creating an awareness and self-promotion. Would you agree?
It is. It's a very challenging line. Some of the most social media posts that I've seen have really inspired me to do more. I mean, I've seen folks post and say, "Oh, I got this nodule," and I'm like, I would never have dreamt of going for that. But then you think about it really hard and you think, well, what are the challenges? Is it possible? And I've seen folks like, I remember seeing someone post a nodule that they sampled on a subpleural surface, and I was like, how did they do that? And then you think about it long enough and you realize, it's possible. So I think those are where some of those posts are useful for folks to realize, this is what is possible with the technology. And when you see different people going for stuff that wasn't possible, now you can do it, it is inspiring. I think there's also the concern that sometimes people post it just for the sake of posting it to say, I did it. And
True.
And obviously we need to be careful of that and mindful of it. Our goal is patient care, not self-promotion.
I got one more question that cropped up, Dominic, if you have a minute. Sometimes folks in academic practices feel that the social media is not a valuable tool, is a waste of time. We should be spending more time and effort in scientific writing, during that time. What are your thoughts on that?
I think we can walk and chew gum at the same time.
I agree.
I personally feel the social media gives you the opportunity to exercise, as we said, that right side of your brain, to be more creative, to share what's happening. The challenge that we have with academic medicine or scientific is that it just takes so long. We have, you do a study, you need to wait for the patients to follow through, you have to do the write-up. It can take you up to 3 or 4 years before you get proof of what's happening. And that, those 3 or 4 years in this field, that's way too long. I think what the benefits of social media is that it allows you to share the progress that you've made. However, again, the folks in the scientific community may push back and say, well, it's not peer reviewed, and that is definitely one of the concerns that I have. We do see some folks publishing data on what they've done, and it's not peer reviewed, and I think we need to hold those folks accountable. I think it's fair for folks to post on what progress they've made, but if they keep on doing that and don't eventually write it up and get it published and peer reviewed and presented at a national meeting, I think we need to be very cautious of following what they're saying, because that's not beneficial to the community. The reason that we would promote it on social media is to create awareness, allow people to know what's coming down the line. But we do need to do our due diligence and make sure that those cases are written up, that those publications are made, so that the field benefits. And I think a lot of people have voiced that concern. And I think when I interviewed someone, they said, yeah, maybe it's obvious to you guys that you should be using cone beam CT, but I've got nothing to motivate to my administrators because there's nothing published. And I think that's where that responsibility falls on folks who are doing research, showing it on social media. They have to get that research published so that the whole field benefits from it.
I would agree. You said it very aptly. I think the social media awareness or education can be a preview or prelude to what's to come in terms of a peer-reviewed publication. I agree with that. It could be a little bit of a blink into through a window of what could be written up to kind of validate what you've claimed on the media. So I agree with that.
Yeah, and there needs to be some way that we pay attention to folks who keep on promoting stuff and say that they've got these results, but then there is no publication that comes afterwards. I think we need to be mindful of that and hold them accountable, at least in person when talking to them.
Correct. Thank you once again. I think that's all about it that I had for the evening. I want to thank you once again for your invaluable time, and hope to have many such sessions more in the future from you and your team.
Perfect. Take care.
Thank you, everyone.
Thanks for the opportunity.
Thanks, everyone.
Take care. Bye.
Thanks, everyone. Have a good evening.